Welcome back, everybody, to another episode of the Vitality Code podcast. I am your co-host, Dr. Jason Farrah, along with my freshly shorn or recently shorn
Got our matching
co-host.
robes on
Yeah,
today.
we got our matching robes. You got the memo. I got the memo. I see that.
trying to get our sponsorship up.
Yeah. Can you guys notice that?
We'll work for free T-shirts.
Absolutely.
Our price is not very high.
I love these Rogue shirts. So I forgot to ask you in the last episode, what was the general family, besides the fact that it was biologically expedient and probably good to be clean and get rid of some of the nasty beard. But I mean, what was the aesthetic response? What was the response to the aesthetic by the family? Did the girls have a response?
It was chaos. They were pissed. Yeah.
What?
They lost it. Yeah.
Seriously?
The middle one got really mad. The younger one was like, "What's going on?" And Bird just laughed at me, the oldest.
Wow. Nyla got pissed, huh?
Yeah, they don't want me to shave it. Because I'd been in the bathroom for a while, it took a while to trim and shave this thing.
What did you use?
Just the hair clippers on an 8 guard. This is an 8.
Oh, wow. So what did you have to pull it out and do this, or how did you
came from underneath and just shaved it, and then I free. The guard kind of screws it up. It's not really made for that, and so it gets a bunch of like loose ends, and so then I just kind of came back with a beard trimmer and just sort of like tried to clean it up so I can go to work the next day.
That took a while, huh?
Yeah, I probably took a good 30 minutes of work in there.
Wow.
Yeah.
Did you worry? Like, did you think, oh my gosh, like Samson, did you think you're going to lose your power?
For sure. I was like, my head looks like a little bobblehead, like a little, I lost my shape. I look like a floating softball on shoulders.
Yeah. A floating softball on shoulders. That's awesome.
I think I lost 10 pounds of my frame. I was like,
that's hilarious. Did your neck? Were you kind of like, man, that must be right?
My neck muscles.
So for the person attempting to grow a beard, I don't know if I can last. What do you do for the daggum itch?
It's
gosh.
worse. It's worse at this stage significantly than you don't feel it when it's really long, but in the interim, yeah. Got to keep it well-groomed, shampoo and conditioner, and then you're not at the stage. But like when it gets to this, I use some balm. I got a routine.
So what do I do at this stage when it's just like this little
suck it up,
buttercup?
Yeah, it'll go away.
So if we look at your chin there and what's coming out from your lip, is it from does the hair go from the lip all the way to what's the length of these things, man?
Yeah.
Dang. Oh my gosh.
It's an 8, you figure.
Jeez.
It's an 8 on it.
I got a long way. So to really make it substantial, how long did it take you? Like 6 months?
Yeah, I've never had it completely shorn, but this right here, it's probably like 6 months of growth here.
Wait, you could get that? You could go from no beard to that in 6 months?
Oh yeah, I'd imagine.
That's a you thing. That's a genetic excellence thing. That's not a. Jeez, Louise. Yeah. Well, we'll see what I can do.
We'll see.
I don't think I can do that.
Put some
maybe if
finasteride on there, and I don't know.
I need to do something. Maybe some Rogaine on my
some
beard.
Rogaine on your beard.
Yeah. Speaking of, maybe is there a peptide for that? Is there a peptide for hair
some
growth?
hormone peptide, some beard growth peptide, like a secret. Well, it'd be banned right now. You wouldn't be able to do it anyway. Jeez, the FDA.
Are they going through with it?
Man, it's a sealed deal. It's been a couple weeks as of, this is in 2024 that we're taping this, so it happened a few weeks ago. They went through and banned. They didn't. So it's a weird, as I understand it, it's a little bit of quasi unknown territory, but the FDA effectively banned a significant portion of the most popular peptides out there. I mean, there's thousands of peptides. There's some ones that insulin. Semaglutide and tirzepatide, one of the most popular peptides out there, subsequently did not get affected. Surprise, surprise. And that kind of lends you to know most likely why they did. Those are billion-dollar industries that the FDA is not going to ban. There you go. 17. What does it say? 17
Well,
peptide treatments.
They are, but they're. I mean, I think I'm on the bandwagon with you, so I'm part of the team. But I will also say, I mean, there's randomized control data that these are good drugs. I mean, maybe part of the thing is
sure.
Why don't the
but there is more. I would say that arguably there's more data that says there are side effects from tirzepatide and semaglutide than there is side effects from BPC.
That may be potential. That may be true.
Now you could make the argument that because there are no randomized control studies on humans with BPC, so maybe we would find some. Right. But to carte blanche go through and ban these with what appears to be no rhyme or reason, it was, as far as I know, it caught everybody off guard. The pharmacy rep just called me on the blue and said they were caught off guard from our compound pharmacy and they could no longer produce these. I've heard from different people. So the big ones are BPC 157, CJC 1295, Imiprelin.
Ipamorelin. It's banned now?
Mm-hmm. So the growth hormone upregulators, BPC was great. We use that a lot in our clinic just because I have, the chiropractic background, so we deal with a lot of sports injuries.
Compound, yeah.
So the
scientific data on that is really fascinating to me. I would like to have.
And I use it a lot for my gut issue patients as well. That's what its origin was. It's oral application, and so. It was a significant blow. I don't know what the outcomes of it. There is still, as far as I know, there's still a manufacturer in California that is making it. So the way I've heard it interpreted is that they banned compound pharmacies from compounding it. They didn't ban the substance. And actually, I think I heard on Rogan's podcast from Brigham that there is a patent already on BPC 157. Not patent, sorry, some studies being done by Merck. I forget.
That's why. Yeah, that's why. I was about to say, just coming to a shelf near you, coming to a doctor near you is going to be Merck, Abbott, AbbVie, whoever. I mean, they're like, oh wait, we missed these. These actually work. How did that slip through there?
Yeah, and no doubt they're not. And they're $1 billion companies, so they're probably researching these and they're looking to patent the doses. They're like testosterone. You can't patent testosterone, right? But you can patent the delivery system. You can patent the dose. Right. You can patent the tweak you put on it to make its half-life longer, its shelf life longer, something like that. Its route of administration different. So those are the things, as I understand, that you can patent. But our compound pharmacies, as I understand, are no longer manufacturing it, no longer using it, puts doctors in a weird place. It's really hard, I think, as a physician. You can maybe speak to this from a surgeon's perspective, but there is safety as a physician from a CYA standpoint as doing the same as everybody else, like the standard of care. If you push into that unknown, you're really exposing yourself. So if you are like, well, these are doing great for my patients, I'm going to keep doing these. And then, someone could make the argument, well, the FDA says that these are dangerous substances and you kept using those, doctors, and none of your colleagues are using these, doctor. Why are you still using them? Are you so cavalier that you think, it just puts you up. It really sets up a potentially, negative situation for individual physicians who want to use these, who found good results, didn't have any issues, but don't want to put their license on the line, frankly. It's going to set up an interesting situation. But I really, really like the BPC for musculoskeletal as well as gut injuries. I really like the CJC and the growth hormone upregulators, and had pretty good results. But I think for now, that I don't know what the big companies are doing, and I don't know how individual docs are going to respond, and I don't know how individual pharmacies. I think you're going to push people to the black market. So that's what a lot of my patients are just going to these, not for human consumption labs. And
I've seen a lot of that.
I've
seen a lot of weird, and there's weird stuff that you can get through that.
Yeah, China and India, you can order it fairly
experimental use only,
use only. Yeah. And that's how they get around the FDA, inspections. And if you really want to see, listening, and not that Rogan's podcast is the go all, end all, be all, but the gentleman on there talks about the difference between FDA pharmacies and maybe some of your standard pharmaceutical companies and their pharmacies. I mean, if we're talking about problems at pharmacies. One of the problems for semaglutide was their factory got shut down because they were improper practices, right? So it's not just
who's that?
compound.
What do you mean?
It was
Novo Nordisk.
Novo Nordisk, yeah, one of their subsidiary pharmacies that they were using to manufacture. It had significant manufacturing violations that shut them down for a while.
Oh, really? I didn't know that.
I mean, I deal with this like just going to the local Publix and having lots of it wasn't Synthroid, but the thyroid medication, I think it was NP thyroid, came back as super physiological doses because the manufacturer had messed up. So these things happen at pharmacies from traditional pharmaceutical companies all the time. So it's not just that they were shutting down and protecting the public from compound pharmacies because they're dangerous.
Yeah.
I mean, they're FDA inspected compound pharmacies. And the one I use, I've never had any problems with at all.
What do we got going?
Yeah. So was this, yeah, so I saw this. So Novo Nordisk is interesting. So the pharmacy that I use, the FDA came out and banned BPC 157, and then I would say about 4 weeks later, Novo Nordisk took that pharmacy to court, saying that their semaglutide was contaminated. 100% of their samples were contaminated with BPC 157. And I was like, well, this is the pharmacy was manufacturing it with BPC 157 prior to the FDA ban. On purpose, as advertised. They told you what was in it. So there wasn't like it was contaminated at all. It was manufactured with BPC 157. Then the FDA comes out and bans BPC 157. Then Novo Nordisk sues the pharmacy for having BPC 157. It just looks so bad.
Look.
You know what I mean? Like, so you didn't influence that? And then all of a sudden it just so happened that, you're saying that they contain this dangerous substance and you were, so I don't know, but I know peptides were in a really exciting avenue for a lot of physicians like myself. And that has been taken away, I think, to the patient's detriment and in the short run. So we'll see what happens. And it drove the price up and it drove everybody to black market. That was the effective use. I don't know what I know people that have good responses using the black market. I know patients who have had bad responses. I don't condone it. I can't. It's outside my purview, my license. I don't tell patients to go there at all. But we'll see what happens.
Jeez. Interesting.
So same thing happened with HCG. They reclassified HCG as a biologic. So a lot of guys could not get HCG from compound pharmacies. And then, so this happened. Yeah. So HCG was reclassified as a biologic, which then disallowed
just a
category. Category. And so then it disallowed certain compound pharmacies from manufacturing it, which then they were meeting the demand for HCG. So they stopped that pipeline. And it dried it up, and so all you can get now is Pregnil, the name brand HCG, and there you go.
March 2020 provision HCG.
And they didn't really enforce it, so it was like they reclassified it, but they let them do it. They kind of like, we're not really gonna do it,
unless they have a biologics license application. Oh my gosh.
Yep, and I don't know that any of those were granted, and so at the end of 2022, they really said, we're going to crack down on this, and all the pharmacies that I use stopped manufacturing it, and it dried the market up. And now it drove the price up in the interim from like $75 a vial. It drove the price up to, I saw as high as $500 a vial for HCG. It's back down to about 200, 150 if you can get it. It's on back order everywhere. No one has it because the commercial version, which is Pregnil, you can't find anywhere. It's just the manufacturing pipelines were not there to meet the demand. And so I don't know what they're doing. And, not that have access to that information, but it just seems to not
what's the
be
point
to
of
the end.
This?
Yeah. I heard in some circles and in some publications that they banned the HCG because people were using it as HCG diet, and I was like, but it wasn't that popular. what the ACG diet was silly anyway, but I didn't know that many people were doing it, and it didn't seem to be a big deal. It was maybe still out there in some small circles. There were no significant people getting injured as far as I knew. I never heard of anybody. It was just a severe caloric restriction diet, and you add HCG for appetite suppression. But that would be gone anyway now with tirzepatide and semaglutide. Jeez. So, but nonetheless, I worry about testosterone, and I worry about what they'll do, for pellets, and what they'll do for compound pharmacies making that as soon as big pharmaceutical interests become aligned with that. So, well, nonetheless,
it's the nanny state, man. This is getting a little bit too much. It's just, yeah. And they dictate what you can do and can't do in medicine. It's just, I don't know. It's tough because there are, it just these big sweeping changes based on the few incidences of whatever. It's like that, like anything in life. Like to punish the masses for that is ridiculous.
Yeah. And the idea of it is great, right? The idea that there's this organization looking out for the safety of the patients is a great idea. Yeah. It just is horribly applied and is run by a government that's inept and doesn't know its elbow from its asshole. And so, when the revolving door between the pharmaceutical companies and the FDA is apparent and obvious, it's hard to trust anything they do.
Yeah.
But nonetheless, we keep moving on.
Man. So last time we talked about CGM, and I'm so excited to delve more into that.
Are they still wearing it?
Yeah, I'm still wearing it.
All right, good deal.
Are they going to take that away now too? I don't know what they're taking everything away. Jeez, Louise. Yeah, it's interesting. I could go on a soapbox. You just wonder. Yeah, they take away stuff, but do they take it away for the elite? Do the elite get the? I don't know. It's just, anyways, whatever.
I'll probably never know because I'll never be in that class.
I will never know.
I won't be able to tell you.
If you're in that class somewhere, can you let us know? We'd like to know. So, are we going to start giving people testosterone to get their A1Cs better, or maybe not? Are we going to start?
Yes.
Are people doing that? And should we be doing that? And should we expect that to be done? I don't know.
I'd make the argument that in certain patient by patient cases, yes, and I do it as part of a comprehensive. Now I do it when there is a corresponding suboptimal testosterone, 100%. I don't think I've ever given somebody with optimal testosterone who has a glucose metabolism issue testosterone. Although I don't know that I've ever seen those. See a naturally occurring 750 and a diabetic patient that come into my office either.
How often do you see a naturally occurring 750 though?
Occasionally, I do.
Occasionally, that's the answer.
Very occasionally, yeah. And I always tell patients it's cool to me because I get this selection bias to a certain degree. Like you generally don't come to my office because you feel great and everything is working perfectly and you feel amazing. And you just want to check, right? It's like, hey, this is happening, negative. I want to check my testosterone. So I don't get a lot of those, but I do still do some primary care, and I do still get patients who are just like, hey, I just want to see if I'm at optimal levels, and I want to check. And you're like, my God, you still exist. There you are.
Well, it's like the white buffalo. Like what's that from the Hot Tub Time Machine? Great White Buffalo, or whatever it is. Like, yeah, it's like it's the Moby Dick, or whatever. Yeah.
Yeah. And a lot of times they're like, oh yeah, no, I feel pretty good. X, Y, Z is working. This is good. I just wanted to check and see where I was at. And I hear all this news and I hear all this talk and I hear my friends and da 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 da. And so that usually doesn't come with like, yeah, well, I do feel crappy. What else is there? It's like, no, I just want to get my numbers. There's a renewed or maybe a new interest in getting quote unquote your numbers and getting some information on you, on yourself, and starting to collect that own data on yourself. There tend to be patients who are interested in cold plunge and sauna. They tend to be patients who are interested in their numbers, their vitamin levels, and part of that comprehensive check that maybe their primary cares are not doing is they want to check their testosterone. They just want to track it like they do their cholesterol. They want to track it like they do their diabetes markers.
So that's a really interesting thing that you just said. So there's this era that's coming about and has been for some time of personalized health, tailoring these things. Are you tailoring these things to yourself, and we have controls of population controls and standards, but what using large data sets and newer technologies like the wearables we're talking about to personalize your healthcare and not just use these static one-time measurements that we look over vast populations of people with those same thing and fall into these generalized categories. Okay, that's one. The next thing is comparing yourself to yourself temporally, temporally rather, excuse me. And I heard Mark Snyder talk about this too. And we mentioned him on another podcast, and and it's not that he's the only one, but it just happens to be the one I heard. And I thought about this, when someone comes in and they're ill, and then what are you doing as a physician? You're trying to fit them into a category that you read out of a textbook, which is based on these bigger populations and kind of generalizing people and things. And all the time, especially in surgery, I'm finding, well, I have to really use a lot of deductive reasoning. And this is where experience comes into play, and that's good and everything. But trying to parse out all the differences between the most likely diagnosis and what you're taught of it versus what you're seeing right in front of you. Now that starts to go away when you look at somebody against themselves. Okay, so here was Jeff in 2000, 2001, 5, 7, 8, and all of a sudden it's very apparent because you're looking at yourself against a different version of you in a timeline, and you can see these abnormals that, oh, maybe you don't meet all the whatever requisites for this diagnosis that we see in a textbook, but for you, but we know you have it, right? And then for you, we know what these symptoms are and how they change over time, and we can see it right there. So I think that's a really cool thing, is to start to track those things, and then look at it in times of health and look at it in times of disease, and you'll be able to probably gain a lot more than you would if you were comparing against these wide swaths of population of people that aren't like you, right?
Yeah, I mean, there's huge interpersonal variability, and I always tell patients, here's what the data says, but honestly, this is based on statistics of large population bases, and statistics do not apply to individuals in one moment, is how I tell them. This statistic helps me infer how you should fit, but it tells me nothing about you. You might be the outlier, and if you are the outlier, then that is 100% of cases. If you're my N of one, then 100% of cases present this way. And so I like to look at labs over time. I like to get their old labs. A lot of physicians, I shouldn't say this, some of the physicians I work with have no idea that you can go on Quest and you can go on LabCorp, which have a ton of data on a patient, and you can find labs for years on there. And
oh, really?
You just ask the patient, "Hey, can I go look up your old labs?" And a lot of times they're housed on LabCorp's online server.
I would have been one of those physicians. I had no idea.
Yeah, so I just bring it up and then I'll print. I'll be like, well, this is interesting, And sometimes, like I had a lady, this was 2 weeks ago, and we sat and we talked, and I was like, I don't think it's your hormones. I think we're just starting to paint a picture of you of this way, and I think it took us a while, right? We drew 2 sets of labs in my office. I pulled her old labs. We sat and we talked. It came out some other information about her, and I was like, I think your hormones look quote unquote normal for the standard, whatever that means, but you do really well. It appears from this hour that we've talked, cumulative, that you do better with a really robust hormone profile.
Yeah.
And she was like, well, that's weird because I love being pregnant. It's the best time of my life. I'd be pregnant all the time, and postpartum was a little tough for me. And so, like these kind of things came to fruition.
Was she an older lady?
Well, I would say no, because she was my age. She was in her 40s.
Oh, that's not what I would consider. Yeah, because one of the things too is looking at older versus younger and receptor downregulation, and these different. So older folks have higher circulating levels of lots of different hormones because they just become insensitive over time. ACE inhibitors, and like if you look at the byproducts of those, and what those are, if you look at blood pressure studies and you look at this circulating levels of, or even endogenous adrenal hormones and things, people become insensitive over time. So there's a theory too that you need higher. Well, there's demonstrated plausibility and efficacy in this, but that older folks need higher levels of hormones potentially than younger folks because of receptor downregulation that occurs over time. So that's why I was asking about but there's also the personalized thing too. You're right. You're absolutely right about that. And that's why symptoms and relief thereof are so important in this line of work.
Yeah.
Right.
And so, I think that the individuality matters. So what I tell my men is, if you've got suboptimal testosterone and you've got a dysregulation of your endocrine profile, i.e. some dysregulation, some pre-diabetic, some glucose dysregulation, then I 100% think that testosterone plays a role in regulating that for you.
Right.
In a positive sense. And I see it clearly in even A1C data lowering significantly.
I do. I think, and I used to make it more of a prominent place in my mind than before. But one thing that I don't like is that I think a lot of people, and myself included, and there was a time where you get this feeling that, and it's because you wear this lens of bias that, like you just said, in your practice and everything, and you see people that come in and they're androgen deficient and they have such dramatic turnarounds when you replace their hormones. I don't know if this happens to you, but I've seen it happen to me, and I've seen it happen to the general public, where you start to blame everything or hinge everything on hormones.
Sure.
And they're very powerful substances, no doubt, and they affect every organ system in the body. So maybe we can't fault people for that, but like, is it the chicken and the egg? Did the metabolic disorder cause this?
Mm-hmm. And so therefore, maybe just fix the endocrine disorder and not fix the testosterone. Is that what you're going?
Right. No, for sure. It's true that, over 50% of the aging obese diabetics will have lower testosterone than their non-diabetic, even obese counterparts. But the question is, how much difference? Like, is it 30-point difference, nanograms per deciliter? Is it 100 points?
Mm-hmm.
And if it's 30 to 40 to 50, if it's something that's less than 3 digits, for instance, what's the clinical ramification of that? It's hard to parse that out. Although on the other side, what you're saying is true, that we do see it in clinical practice that people's A1Cs tend to improve after being placed on testosterone. And we do know there's scientific bench research type biochemical data that demonstrates the effect of testosterone on the adipocyte, on the muscle cell, making it a better regulator of its metabolic processes, just to keep it simple. Interestingly, testosterone, if you look at pluripotent stem cells, tends to produce more of those that develop into muscle than those that develop into fat. It's pretty interesting if you bathe them in testosterone.
State, oh, interesting.
Yeah,
which makes sense.
Yeah. So, and it even causes the adipocyte to become a more efficient cell and less and more sensitive to the effects of other hormones. So you can, if you have the proper amount of testosterone in your body, you can burn the fuel contained within that adipocyte easier than if you did not. But the problem is, I get worried that I myself would even try to almost prescribe testosterone for a diabetic to help them with their diabetes, rather than, now I've changed my viewpoint to what you said in an earlier podcast was, I don't know if it's a chicken or the egg, but I know that there is a circular relationship there, and one will help the other. And so let's do both. And I think that's the key. And so I look at these foundations of vitality, and I think hormones is one of the foundations. I think your glucose regulation, your sleep, your how you handle stress, and the sense of community, and the building of muscle, and the balance and strength and coordination, and these pillars, right? And if you get the testosterone hormones right, it will help all the others, but it's not in and of itself a panacea.
No, definitely not. And I think it's a couple of things. I think this is why it's important that as a physician, we're always imposing objective checks and balances on ourselves, because it's easy to become biased.
Yes.
It's easy to become biased because there's a financial interest in it. There's easy to become biased because it's just selection bias. And so it all starts coming in. So you just think everybody has it. You tend to remember the really good responses.
Recency bias. Yeah.
Recency bias. And so I always what I really try to make myself do is I make the decision, the patient's decision. I try my best in every single patient interaction to say, here's the information, here's the data, here's the pros and cons of these 4 decisions that we can use to attack. So let's take this diabetic situation or pre-diabetic situation. Here's your options, sir, ma'am, X, Y, Z. Here's the pros and cons of this one. Here's the pros and cons of this one. Here's the pros and cons of this one. Which one would you like to do? And if you look at testosterone as a piece of that puzzle, there's a pro and there's a con to it, right?
Mm-hmm.
And that's not my decision necessarily to make. It's my decision to give you the information as unbiasedly and as objectively as I can. And it's your responsibility to be as objective within yourself to know how that fits for you. And I need to honor that. So if you tell me, like, I really like to give it a shot I don't want to be on any medications, even if it's testosterone, I don't want to do anything. Can we do it the other way? Yes, 100% we can. And that's something that the patient needs to have the purview to do. But also on the flip side of that, if the patient's like, I'm tired of fighting a fight that I feel like I'm not winning, I'm tired of feeling like garbage, which one of these will provide me the quickest boost to get to where I need to be? Well, that would be adding your testosterone, doing proper diet, and doing proper exercise, and maybe semaglutide. Right? It could be all of those things. And they may say, like, oh, that one scares me. It's really new. I don't want to do the semaglutide. Okay. I'm having a hard time exercising. Maybe I want to include the semaglutide, right? Those are their choices as opposed to me dictating that to the patient. Because as soon as you start to dictate that to the patient, I think that's a slippery slope of objectivity and biasy is heavily what finds its way in there.
I agree 100%. And I try to give them a box. And I say, in this box, these are the safe options, and let's go through these safe options. Mm-hmm. I will give you because I think it becomes difficult sometimes for patients, and I've done this is where I get so there. I try to avoid paternalism so much that it's almost like, what the hell do I do? So I try to give them some borders. That's one thing I've added.
Well, and also a lot of times patients will say, what would you do?
Oh gosh, I know, all the time.
And that's also, I have to remember, sometimes they came to me, so that means it's an issue they want to address, and they do want my opinion. So tell me what your opinion is and address it. You got to remember that too.
And I do, and I always, like, for instance, if I'm signing up somebody for surgery, I always say, but you have to remember, I'm seeing this through a surgeon's lens, which is a bias, and I cannot get rid of that bias. I mean, you wouldn't come see me if I didn't have that bias. You wouldn't go see a non-surgeon so you have to remember. But I'm also, I don't know, just my makeup and maybe how I was taught. It sounds like you have a similar makeup and you were taught similarly, or whatever, however you developed it. I just can't not say it. I want to admit it, and I want to put it out there so they can make the best decision. But I want to freely admit that there's bias. I mean, I'm not, so. Mm-hmm. No matter, at the end of the day, I at least told you, and we did this together. So I had a woman come, or see us for a consult, and she had massive so she was obese. Her main complaint was obesity and wanting to lose weight and wondering if there was a hormonal component. She was sent to us by some folks that are fitness coaches and macro experts, and they went down that pathway first with her, and then when those things arose through questioning, they sent them to us. So we took her labs. She had, oh my gosh, metabolic derangement of every sort, of which included a non-existent, how it says incalculably low or less than, it doesn't give you a number. Testosterone was gone, just gone. Her hemoglobin A1C was like 5.9 or 6. It was like, it was high pre-diabetic, but not yet diabetic. She was morbidly obese. Thyroid, but that was being treated by someone else, but it needed some tweaking. And then she had high CRP, high homocysteine, some other things that, we could take care of. Low, her vitamin D was like 10. It was like, okay, so there were some quick, easy fixes. Put her on some vitamin D, da-da-da-da-da. And then the basic decision was down to 3 things. Do I get on testosterone supplementation? Do I get on medical weight loss therapy with semaglutide, tirzepatide, or do I get on both? And her budget came into play. She's a school teacher, and that's fair. I was like, you're doing the Lord's work, being a school teacher. God bless you. I don't know why we don't pay them way more than we really should, but nonetheless, and I'm sensitive to that. I don't want you going out and spending much money either. So here I am biased and have a financial incentive, right? What am I going to make more money on, quote unquote? Medical weight loss, hands down, right? And she's got morbid obesity, and she's got a high A1C, and we can improve all that. But I had sold her. I was like, so that's what it took. It took some questioning, like, what's bothering you the most? Are you having symptoms of libido issues, dyspareunia, different things like that? And oh, by the way, it came out that she had some progress with the fitness and macros counting. She had no idea what macros were and wasn't really into fitness her whole life. But after a couple months with them, had lost like 14 pounds on her own without doing anything. And I was like, well, geez, sounds like that's working. Don't jump off a winning horse. And why don't you just get your hormones? We'll make things more efficient. Here's what I would do. Kind of, I give her my opinion, and, but it's hard to know in that person which beget which. Number one. Number two, it's hard to know sometimes it's difficult kind of crossing that, or, just navigating that terrain with a patient, right? And I don't know how you navigate that, but what would you have done in that situation?
Yeah, it's a tough one. What I try to do in my assessment is I'm trying to assess the patient from a medical standpoint, and the reason I have longer talks and longer initial assessments is I'm also trying to evaluate their emotional makeup and where I think they will do the best. And so I usually will end my conversations with asking them what they want to do. And then inevitably it comes back to, well, I came to you, you're the expert. And I say, what I hear you saying is that you will likely do best with this. Or what I hear you saying is that financially, these are the best options for you. Or what I hear you saying.
Yeah.
And
were you taught that, or is that something you developed? I like that. I don't know if you even realize that.
I don't know.
That's
important.
I
wasn't taught by anybody, but so I try to do the best I can to put myself in the patient's shoes, and I say, like, this seems to be a really tough journey, and you seem to be really struggling, and you would like every option down the table that you can do. Does that feel true to you?
Mm-hmm.
And if they're like, yeah, I can't, or like, no, I think I'm okay, or you can kind of gauge their response and see if you got it right, and then based on that response, I try to get them to elucidate an answer best I can, and then I say, well, here's my recommendation based on what I hear you saying.
Yeah.
So I try to leave that for last. In those cases, though, I find it's difficult because the patient, like you described, potentially is in a severe state where it's going to take a lot of wins to beget future wins.
I know.
And so it's like, if you could start off with a bang, it would really help, but then you don't want to pigeonhole somebody into a lifelong treatment. I find this with my tirzepatide, my semaglutide. I tell patients, a lot of times they're scared. They want to be on it forever. They don't want to, be pigeonholed into it. They don't want to have to, what are the future consequences? And I tell them, my goal for you is that I will always keep open a window for you to come off of these medications. Whether you come off or not is a decision for you to make and a decision for us to have, but I will always keep the window open for you to know that you can come off these if that's a choice that you make. And different patients have made that choice at different times, and some have chosen that it's going to be a longer journey, and the benefit of being on it outweighs the benefit of being off of it for them for various reasons. But the option to come off is always there, and we will always honor that decision. And I also like when patients are on a subscription-based service with me, it takes a lot of that financial biases out, right? You're paying me a fee monthly that won't change. And whether I find you labs in my office or with your insurance, or whether I find you Pregnil or I find you compounded HCG, those don't change how much you're paying me. So it helps take away some of that financial interest. So I found that with the subscription model, actually, it helps take away that, because I'm not looking for add-ons, right? I'm not looking for, well, your insurance is going to ding me if I run this on your lab, and I won't get my kickback at the end of the year from my managed care, so I don't want to run an MRI, so I'm going to refer you to the specialist. I saw that when I first started out, I remember them telling me when I was doing my preceptor rotations, that insurance company really doesn't like you running PSAs on patients. I'm like, what do you mean? I have to run that, but they don't really like it because it's an expensive test. And we don't really like to run the MRI because, it dings us at the end of the year for a kickback. They wouldn't say it that way, but that's what it was. So we referred to the specialist and let them run the MRI. But when you're on a subscription model, I don't get a kickback from the MRI. I don't get a kickback from LabCorp. I don't get a kickback from Access Labs. I don't get a kickback from the manufacturer of Pregnil. And so I'm like, I found a pharmacy that's selling that same medication cheaper. Let's use that. Or actually, if you go to Publix on Mahan, it's cheaper than if you went to CVS because I went to the GoodRx app. So you can kind of navigate those systems independent of that financial biases. But really, just trying to put myself in the patient's shoes. So what did she end up doing? Balancing her hormones, because that's going to definitely affect her weight loss capability, right?
Right. So that's what I said.
And did she do the weight loss?
Ideally, it's no, not yet, because she was already paying these people to do their service. So I was like, good God, I mean, that would be one, which is fine, and I think she should, and she already had good success, and it brought her to us. So what we did is we're gonna fix her thyroid using her insurance, so no cost there. Vitamin D, that's negligible cost.
Yep.
And then the hormones.
So tell us about the hormones and the weight loss. How is that testosterone optimization in her going to affect her ability to lose weight?
Well, that's the thing. I think, so it makes you wonder, should I have treated the chronic disease? And maybe that would have, and it's the chicken and the egg. To me, it was the additional symptoms of dyspareunia and low libido. But would have those, I don't know. Well, her estrogen was okay, so I don't. It gets tricky, but we're not getting too far. Let's just call it low libido, because maybe I'm remembering it wrong too. I don't. Anyways, but because it does get tricky. But I think her estrogen was okay. But
just what do you tell the patient how the testosterone optimization is going to affect their weight loss? Like through what avenues?
Well, that's the thing. So number one, it's going to be working at the level of the brain. Okay, increasing dopamine and serotonin and increasing motivation. We know,
which is significant.
And there's compelling data. Huberman talks about this recently in his lab, but it's been around for a while, that testosterone affects that part of the brain dealing with motivation. So the question is, can you go in and do these large compound movements using large compound muscle groups, squats, bench press, and thereby increase your testosterone naturally as you increase your glucose regulation, as you get rid of your chronic? Yes, you probably can.
But in a patient like you've described, I've never seen it happen.
Exactly.
In a young, healthy patient, I've seen increases in a presumably young, healthy, a few males. I've never seen a female, not that they've gone down that route, but I can think of specific few young quasi or quote unquote, not quasi, quote unquote healthy males who were just interested in upping their levels and wanted to see what the effect was. Yes. Like 30-something-year-old males who are healthy.
So you're talking about the physiology of a 30-year-old versus the physiology of 70, or are you talking about the mental attitude and actually getting to the gym?
I'm talking about the physiology. Well, probably both, as a matter of fact.
Well,
but the physiology, I think.
That's a good point.
A non-disease state individual boosting their testosterone versus a disease state individual, whether or not they probably just couldn't put in the physiological amount of work necessary, because it's tough to work out. It hurts. You know what I mean? But
enhanced
someone who's already trained. Yeah.
Yeah. So that's another point. It's going to change your physiology. You're literally going to be able to have higher influxes of calcium into the sarcoplasmic reticulum. You're going to have better muscle contraction. Grip strength's going to increase. I mean, all these things are going to...
Recovery's better.
Recovery's
muscle mass
better.
Development's better.
That's right.
Wins beget wins.
Right. So I did go through I said basically, and this, I'm not trying to cure your diabetes with testosterone. But it is a fact that an improved testosterone profile is correlated. I don't know if it's causal yet, because the data hasn't made that link. The data shows that these cells are better at processing glucose. The data shows that these cells are better at mobilizing lipids from their stores, but it doesn't quite prove just yet. But what is true is that you're doing those things anyway. And if we can make your body a more efficient machine, then you'll have a better result. You'll get to a 90 instead of a 70, or you'll get to whatever is your end goal. And that's going to be enhanced by testosterone. Not only that, but
I think the bigger point to this is, no matter what this woman chose as, I'm going to start with A, B, or C, in the end, I think the journey will play its course out. I think the bigger picture is like, Jane, let's give this a year. I'm not going to start you on semaglutide right now, tirzepatide. I want to give you 3 more months on that, but it's an option if you want it down the road.
And we talked about that, right?
Right. And so, and also as a physician, when you have a smaller practice, you're able, like, this is a discussion that you're having that will definitely influence her decision-making down the road. So you're providing patient care right now, even without her being present, because you're thinking about these answers. What's best for her? I didn't want to tax her financial budget. I didn't want to tax these other things. And she was already doing really good here. So I wanted to give her that win doing the diet and exercise before we put her on semaglutide. But so the journey may look kind of meandering, but in the end, if the physician's invested and the patient's invested, how you get there versus 3 right turns or 3 left turns, hopefully you still get there. And there may have been a quicker route, there may have been a better route, but as long as you find the route that is best for that patient, I think that's the ultimate 30,000-foot view issue that's being addressed here. And the fact that you're even questioning it, right? As opposed to, I got 6 minutes with you, start semaglutide, start testosterone, and keep doing your diet. I'll see you next week. I'll see you actually next year.
Right. You're absolutely right. And tailoring it to your specific patient is the key.
Yeah.
I find that the literature, like one of these articles I read in preparation was this one by Grossman et al., or 2014 review from the Journal of Endocrinology. And it's a balanced view of things, and it's good. But you I don't know if you pick up on this, but I pick up on these. There's like a tilt in these articles, like, oh, it's almost like, you guys are trying to cure diabetes with testosterone, and clearly that's not going to happen. I mean, but they don't talk about the other things, and they also don't talk. It's like, type 1 and type 2 errors. We don't have to get into that, but I mean, there's just the corollary that they don't seem to mention. I mean, and so I guess at the end of the day, trying to figure it out, you come back to what you said: staying with the patient through the process, talking about all the different options, understanding the physiology and the anatomy and the biochemical response. Helps them make a better decision. That's an informed decision. Help them navigate through those if you understand it. So
I've never seen someone's diabetic state or pre-diabetic, whatever you want to call it, cured by testosterone.
Right.
But I still always recommend it as a potential option if there is dysfunctional testosterone levels, as something that will help, even though I've never seen it cure. And in fact, I've rarely seen, in my pre-diabetics, certain pharmaceuticals work. To me, it's more about psychological changes and them taking it seriously and them making lifestyle changes, which are really, really difficult. And that is the bigger influence, I think, on all of this. When you talk about lifestyle changes, what's between the ears is so much more than what's, going in your syringe or what's going in your pharmacy pill and these kind of things. Like, you've got to take this seriously, and you've got to make some significantly hard decisions over the course of a long period of time that are probably going to butt up against some significant psychological predispositions that you may have about food and lifestyle and family and stress and workload. And all these things are so much bigger. And that's really the determining factor, is when those things are addressed, I think, ultimately. And sometimes, but I can't address everything with you, and I'm not your psychiatrist, but I strongly recommend that you talk to somebody about your eating habits, and I strongly recommend you talk to somebody about your family relationships or whatever I can see as a cause. I'm going to deal with these issues and help you along the way, but I think it's the community, and the community support plays a big role in seeing other people make wins, and that you can make wins, and long-term lifestyle changes, long-term. Long term.
That's the key. I think that in summary, I think there's a bi-directional relationship with testosterone. Yes, metabolic disorders do lower it. Yes, low testosterone begets these metabolic disorders. So I think, the answer is, the chicken, the egg. Is it the chicken or the egg? I would just say yes. I wouldn't say it's either one. But I think ultimately you hit the nail on the head. It comes down to providing that in the framework or the substrate where you're looking at the long-term ramifications of the most vital life you can have, the most healthful life you can have, the long-term ramifications of all these other things that are in your life, the psychological implications, and making sure that these, it's the big bang for the buck, these pillars: the sleep, the exercise, the nutrition, the hormones, yes, the socio well, whatever they are, the social dynamics of being a human and addressing them, they all work together. They're all synergistic.
Yeah.
And I think that's what it comes
But there
down to.
is some significant, I tell patients too, like you're going to put on some muscle mass from taking testosterone.
For sure.
That muscle mass will make you more metabolically active, which will improve your ability to deal with sugar. Like there is a direct link that I could tell you how it works and also I look back and I'm glad it was suggested to me that I start testosterone. I look back at doing testosterone now. Right at the end of the day, if it wasn't suggested to me, somebody who had significant, like I was on zero medications up until the point, never. You know, well, actually, I've been on some disease states, but never lifestyle medications at all. No blood pressure, no cholesterol, no diabetes, nothing like that. Yeah. And it was a big hurdle, and I looked at it almost like I had failed, or I looked at it as like now I'm quitting, or I've started this new thing, or I've gotten old, or whatever that. Like it was like, man, this is not. I'm not going to do it. But now I look back, and I was like, I tell patients, because I had this. I think I wish I'd started it a year early. And I've made so many other betterments in my health that whatever negative that could come from me being on testosterone, the cost, the time, the effort, the money, the potential side effects, is the benefits severely and drastically outweigh any potential negatives. And I'm emotionally, financially, physiologically at a better state, I think directly because of that. Not like it was the sole reason, but it definitely played a role that I can follow.
It did. I think that was a genesis of something in you, and I think that's what I tell people with testosterone is that it's not. Again, I kind of thought. I have to be honest with you. I think I thought. I don't know if I consciously thought, but I definitely had I feel like in the retrospectoscope there, I had this wonderment because I saw a lot of big changes, and I almost got to feeling like testosterone was some kind of panacea. I don't, but I do think it's a very powerful change agent, and I think it plays a massive role in a more complete framework that has to be in place to get those long-lasting and permanent changes that are significant. But it's like, it's got to be there. You got to a key to the car won't get you to the next destination, but it will turn on that car, which will ultimately get you to the destination.
I was already working out. I was already doing all these things. I was just getting zero results from them. I was feeling like garbage. Right. So it was maybe a nice plug and play because I already had the discipline, already had the exercise, already had some dietary stuff. And I think testosterone for me, I tell this to my patients, like I do not envy the medical doctor who has to rely on nuanced benefit from medications or lab result only benefits, like, oh, well, you're taking this statin and your cholesterol is lower, you're doing good, and the patient's like, okay, right? My patients on testosterone, I tell them from the outset, this should be a clear-cut positive in your life, because I find that if it's not, it's too much work, it's too much extracurricular to patients don't stay on it. It weeds itself out, right? If you didn't really need it, and you're not really getting much benefit from it, you won't continue to do it. It's not an anabolic steroid. You're not going to become Mr. Olympia. Sure, you'll put on 3 to 5 pounds of muscle, and that's cool, but that's not enough for you to go through the time, effort, and money to do this. But if it is a significant player in your life, you're like, this is big for me. I'm going to stay on it. And so I think you either have those systems in place and the testosterone feeds into them, or the testosterone is the impetus to now put those things in place. And I've seen both of those happen.
And the cool thing about it is that it's already a biological system blueprinted into your DNA.
Good point.
Where there's no blueprint. I mean, like we're enhancing a blueprint that was already there through evolution, creation, a combination of both, whatever, it doesn't matter. And you're enhancing the DNA. Whereas in the other subset, we're kind of working against our DNA to override something. And so, yeah, it's natural. It's natural. I mean, quote unquote. We talk about natural. I mean, it's natural. So it should be very I like what your framework. It should be very evident. It's so natural. It's in your DNA. It's in your machinery. The cellular biology is already there. That it should be instantaneous. It's not that medicines aren't, but they're kind of counteracting it. So and something that we always find later on is that there's always all these. When you look at a test tube and you look at one thing in a silo, and I remember this with was it activated protein C? There was some big, was going to cure sepsis and for surgery and trauma, and it ended more bleeding and worse outcomes, and they had to stop studies. I can't remember. It was back in the day. But anyways, because you just don't think of it's hard to account for all the counter-regulatory things in the human body. But this one was already there. This was already there at the beginning of time, at the beginning of, so it's part of being human. So you put it in and you let it go. Whereas, you can't, you're not sure when you're doing the other ones. But anyway, it's so much so that if it was what you were missing, it should be very evident.
Yeah. Absolutely. And I think in specific in relation to insulin and glucose dysregulation, it improves muscle mass, which improves your glucose metabolism. It improves how your exercise levels. It improves your drive. It improves your recovery.
Energy process,
and all those things improve your glucose metabolism, which actively I see from a practical standpoint, and specifically in my patients, it drives down things like glucose variability and it drives down A1C. So it does have a place. Does it cure it? I've never seen that.
No.
And I would make an argument that it doesn't. But it does play a significant role, and it can be a driver to impetus to change in a pre-diabetic patient.
Yeah.
And get them the win. Just like semaglutide could be for a weight loss patient. When they come off it, the appetite is going to come back, but it could reset their metabolism. It could reset their caloric intake. It could reset their ability to view how these things can happen in them and how wins can happen.
And their psychological makeup of their habituation and forming a habit. I mean, it's if you're on it long enough. So, yeah, absolutely.
So, all right, brother. As a synopsis, I don't think it's going to change the world state of diabetes, but it definitely plays a role, and it definitely improves it, and I've seen it time and time again.
I've seen it time and time again, absolutely. All right, man, it's been a good one.
Yes, on that note, I got to go work out.
You know what? I think I'll go work out too.
I got to go get ready for my marathon.
Oh, that's right. So are you not doing CrossFit, or are you just going?
So I had to pull back on CrossFit. I try to get in one day a week, but I've got the volume of training needed for this is just not conducive. I want to keep my jiu-jitsu up, so I'm doing running. And then, of course, the holidays are screwed everything up.
Yeah.
But
so how far are you running today? How far are you running today?
All right, I'll do 8 miles today.
8 miles. Why are you laughing? Because you weren't going to do much?
I don't know. Because if you make me say it ahead of time, then I've got to do it. But if I'm in the middle of it and I haven't set a goal, then I can. 4 is good. Baby. 6 good.
8 miles.
Stacy did it yesterday.
Oh, she's doing it too?
She did it yesterday. She did it out on the farm. She ran out in the sand, and she's like, "Oh man, that was tougher in the sand." And
who's the better long distance athlete? I'm gonna say
100% Stacy. 100, no questions asked.
Yeah, I figured.
She's like, "You're doing good. You're doing good." I'm like, "Leave me alone. I'll just stay with you. It's okay." I'm like, "No."
You got more of the fast twitch in you, I think.
Yeah, like we were on that the day before we got sick. When we were talking about last time, that morning we got up and we were at the top of a mountain and we did some sprints and lunges up the mountain, and I crushed Bird. Just absolutely destroyed her. I was like, yes, old man. But then you put me on a 4 or 5 mile run, and I'm just like, this is just brutal. Stacy whips me every time.
Is it a mindset thing? You get bored, or is it cardio? What is it?
I think it's my metabolic and muscular profile, as well as like my joints, my ankles and shins and feet just have never done this, and they don't like it. Yeah. And after like 45 minutes, my brain's just like, you should quit. You should quit. You should quit. You should quit. Like it just constantly tells me I should quit. And I'm just like, shut up. So it's a misconception that it's easy for anybody. I think like my brain is always lying to me about you're done. You did a mile. You did 2 miles. You're good. Just that little whisper in there. Like, I need like a David Goggins style person yelling at me when I'm working out. Just berate me. That's what I need. Just like I want to complain, but just don't listen to me and just tell me how much of a sissy I am.
Just let me bitch and just beat me up.
I'm gonna bitch and complain. Your job is to not listen to me and further turn up the abuse. That's what I tell people. But if you expect me to be like, oh, okay, yes, coach, I'm gonna do it. No, I'm gonna yell and I'm gonna bitch and moan and complain.
Yell right back at you. Yeah. Yep.
You just gotta be louder and more persistent than me, and I'll do it.
Oh man. All right, man. Well, good luck on the run today.
Yeah, I'll let you know how it goes.
All right, let me know.
See you, man. Have a good one.